Can I have the first slide, please? So jumping straight in with the key practice challenges that we're facing in East Sussex and Brighton and Hove. The first one is really about how you set systems up to effectively support women with multiple complex needs who may not meet service eligibility criteria or who might struggle to engage with the ways that services work. And alongside this, ensuring effective information sharing and collaborative working across agencies. One of the issues that we really struggle with is sustaining support across services and ensuring joint planning for release from prison when women's prisons are located out of area quite frequently. So that obviously disrupts any progress that women might be making with local support teams, but it equally provides very little time when they're in the estate for engaging constructively with the specialist mental health and substance misuse services and achieving any lasting change there. We know that 6 out of 10 women are leaving prison with no safe accommodation to go to. That was the information that Karen sent out from the Safe Homes for Women Leaving Prison initiative. And also that a third of street homeless women report domestic abuse as having been a factor in their becoming homeless. So our response and the service and accommodation environments that we offer really need to take a trauma and psychologically informed approach. Can I have the next slide, please? So clearly some of the barriers that we've encountered are that women are finding barriers to being accommodated in that they're being challenged on having no proof of domestic violence and abuse. They may not report their abuse to the police, and so there isn't a record of it. They're quite often deemed as being intentionally homeless or having abandoned properties that they've been given. And quite a lot of them show an unwillingness to be housed out of area. We do hold out some hope that the Homelessness Reduction Act will help address this type of situation. So, as you'll be aware, the Act places a duty on local authorities to relieve homelessness regardless of price and intentionality. And while that doesn't equate to housing provision per se, the process does involve the production of personalised housing plans, which do offer new opportunities to work with all rough sleepers and obviously women who are rough sleeping in a more proactive way. Can I have the next slide, please? So over the years, safeguarding adults reviews, domestic homicide reviews and drug and alcohol related death reviews in Brighton and Hove and East Sussex relating to women with multiple complex needs have really thrown into sharp focus the scarcity of multi-agency mechanisms to bring staff together across agencies to plan and review their work involving cases with a high level of risk and complex needs in a kind of team around the person or team around the adult approach. This is obviously particularly challenging when you're working with people who just fall just below the service eligibility thresholds for care and support needs under the Care Act or the statutory safeguarding frameworks. And then that can result in a lack of a coordinated response with no identified lead agency. Applying the making safeguarding personal approaches in circumstances where there is coercion and control, chronic self-neglect being a feature, consent issues and also difficulties with engaging clients really requires a high level of skill and knowledge, and practitioners are also required to weigh up individual rights, statutory duty, risk and benefits, while also promoting resilience, recovery and well-being. So it's really skilled and assertive and proactive work. Can I have the next slide, please? So in addition to the lack of multi-agency mechanisms and the team around the person approach, there are some other systemic issues that we've encountered. So the impact of the pandemic, and in particular the lockdown, has resulted in a loss of bystander approach, response. And if it's all right with Karen, I can forward an evaluation of some work that's been going on in Devon around the first UK-based bystander programme for prevention of domestic abuse in in general communities, and I think that's something that we'd like to see rolled out in other areas. There's obviously the uncertainty about the future, where rough sleepers were placed in hotels, and a lack of clarity about what will be happening with them should there be a second lockdown and through the winter, in terms of the more hostel-like provision that has typically been available for street sleepers. The whole issue of hidden homelessness for women. So we know that rough sleeping is a really dangerous way to live for anyone, but especially women who are vulnerable to attack and sexual assault from both the street community, but also the general public. And we know that the way the data is captured doesn't always give us the full picture, and that's what St Mungo's was saying this morning, because women might avoid male-dominated services, they might be more likely to hide at night when the street counts happen, and they might be disguising themselves, especially when sleeping, as men. And we also know that women might make what seem to professionals to be poor choices. But if you think about it, how safe and appropriate is the accommodation that's offered to vulnerable women for rough sleepers? And is it more a question of people being forced to take the least bad option, for example, exchanging sex for a roof over your head, or choosing to be with an abusive partner who you know of the risk of random assault? And the other systemic issues that we're facing are that there are constant funding cliff edges. So we have initiatives like Fulfilling Lives and Making Every Adult Matter, where intensive key working and case working comes and goes with very limited systemic change. Slide 6, please. So for my bit here, in summary, the questions that partnerships really need to ask themselves, I think, are how effectively do safeguarding and domestic abuse systems and homelessness systems work together locally for people who are victims and perpetrators, or both? In working with people with complex needs in relationships where there's domestic abuse, how well do agencies understand the different roles, remits and restrictions that partners are working under? And what's helping and hindering us in working preventatively with women with complex multiple needs? And how can we best tailor our responses to them? And a final point there is how easy is it to currently respond well to women who are pregnant or who've lost the care of or contact with their children when they're actually reaching out for help to regain contact? We know that when a woman's pregnant, she's treated with a lot of care and attention, and the moment she loses her children, which for some of these women is at birth, then she becomes just another client, and there are very few services that are set up to work with this specific grief, trauma and loss, with PAWS being one notable exception. I'm going to hand over to Rose now, who will talk about a specific case study. Rose?
Thanks, Vicky. Great, so I've got on the right slide. That's lovely, thank you. So yeah, we thought it would be useful to actually talk about a case study and put it into kind of a bit more context. So this case study has come from an organisation called RISE, which is the local DA provider in Brighton and Hove. And this particular worker is a navigator role. So it's funded by the MHCLG until the end of March currently, but possibly be extended past that. And she's part of a multi-agency team called the Navigators, who are made up of an adult social worker, substance misuse worker, a housing officer and an occupational therapist. And the caseworker had been working directly with the client for 18 months and her support focused on supporting the client regardless of what choices she decided to make about her relationship, and ensuring that she had options and safety planning advice that she needed at the time. And also kind of supporting her more generally in areas such as self-esteem, finances, physical health and practical support. So just to give you a context of the sort of service that this case study's come from. So the client is in her early 40s. She's lived in Brighton and Hove for her whole life, and she is currently experiencing abuse from her male partner. They're both housed in separate accommodation, but also choose to sleep out together. The client had a history of abusive relationships, and she also has a number of long-term physical health conditions, and she also has support needs around heroin and crack addiction. If I could have the next slide, please. So in terms of the client's housing history and what learning we can take from that, the client was placed originally in a hostel, but she was hardly ever using the room as she was choosing to sleep out with the perpetrator, which was due to the risks of the repercussions from the perpetrator if she didn't do that. The hostel placement was a strong protective factor for her because she could have somewhere to go if as and when she needed to, and a safe space. However, after a period of not being able to stay there due to the threats from the perpetrator, she was eventually evicted as she was classed as abandoning, and she was given 2 weeks' notice of this. She was then placed in a different hostel, also in Brighton and Hove, and the domestic violence outreach worker who was working with the client was able to engage with the staff at the beginning and kind of work with them, raise their awareness around the pressures that the client was under and the risks that she was facing, which might result her in making different decisions about whether or not she was able to stay at the accommodation or sleep out than was expected. And in addition, the client was supported to present and be more present in the accommodation with some safety planning around the risks around that, so kind of how to manage it safely, that she could be present a bit more. And there was more flexibility negotiated with the requirement to be present with the housing provider. So the outreach worker also arranged to kind of be kept in the loop about if eviction was ever being considered, that there could be some discussion about how to manage that. So I guess the key learning from that was that the risk of eviction to that client was less dangerous than the risks posed by the perpetrator, which led to eviction, which then increased the risk to the client. So just kind of reflecting really that kind of cyclical nature that we can sometimes see. Next slide, please. So in terms of her health history, the background in terms of her health was that this client had a number of long-term health conditions, and her health and well-being suffered when she was living outside. And she wasn't often able to engage with standard health interventions due to the level of control by her partner. So what worked well in that scenario was that the homelessness health team did some really assertive outreach with her, and they tried multiple times to go and find her at different locations. And then when they did find her, they used a really flexible and supportive approach to how they engaged with her for that session. And they also, they used really, one thing that's really useful to use is creative and multiple engagement attempts. So, for example, trying to use the phone, letter, email and contact via another trusted professional, we have found to be the most successful, rather than having an approach that would just focus on one of those, because for one client, they won't have a phone, so a letter would be better. Another client has a safe letter address, but they don't have an email. So it's just about trying to be really creative about how they engaged with each person on an individual basis. And also on that occasion, they did also engage with the perpetrator. So in that scenario, the victim actually asked the health worker to go and speak to the alleged perpetrator, who was also present, but in a different room, and actually go and speak to him and say, this person needs to go to the hospital to get urgent medical attention. This is really dangerous. And actually the alleged perpetrator then allowed that to happen, basically, without fear of repercussions for the client. Next slide, please. So the key findings, I guess, overall are that involving a specialist worker in the conversation is really valuable, because they can add that nuanced approach to how something might be safely managed or how you might engage with a client, and to be led by the client about what will increase their safety, even if that seems counterintuitive from an outside perspective. So some practical tips might be, in terms of housing, managing the expectation of frequency of how often the client will be present at the accommodation. Consideration, again, in relation to housing, consideration of allowing perpetrators to visit the victim if the victim identifies that that would decrease the risk, i.e. they're less likely to stay out on the street where they would be at risk from multiple avenues or multiple people, and there's also less support available and less people perhaps willing to kind of listen and see what's happening and raise the alarm if there's concern. Also, another example regarding housing could be consideration of housing the couple within the same accommodation but within separate units to enable them to have their own safe spaces and reduce the risk that way. But one thing it's important to remember, I guess, is that occasionally you might see examples where clients want to work towards being housed together if they can safely manage their own units. And one risk to be aware of with that is that if that is the case and the clients are working towards that, they may well hide the abuse more. So they might not feel able, the client might not feel able to disclose abuse if they know that there might be an impact on the ongoing housing arrangements. Next slide, please. So key findings, consideration around if the alleged perpetrator's housing is likely to change is really helpful. So if the perpetrator is going to be evicted from a hostel, for example, flagging that potential increased risk to any support workers that are working with the client is really useful so they can help manage that risk. Considering the training needs of housing support staff, security staff who might be the only people present overnight, for example, and hearing or witnessing incidents, and obviously any health staff settings. And I guess something to focus on would be about a one size doesn't fit all approach. So with health and housing policy, if there's any scope to make policies more encouraging of staff to be more flexible in their approach and giving training to those staff so they feel really confident in how to respond to quite complex situations. And working towards a kind of person-centred, client-led approach when making decisions about the impact, anything that impacts on the housing or the health or safety of those clients. So that's the case study. I'll hand back to Michaela now, who's going to finish off the presentation.
Thanks, Rose. So just to say what we've been doing in response to this in East Sussex and Brighton and Hove. So for the past 18 months, the joint unit, which is also working across West Sussex in terms of the strategy, have developed a Pan-Sussex strategic framework, and we're currently re-tendering the specialist domestic abuse and sexual violence services. And we've had really significant stakeholder engagement in this process, which really highlighted the need to review our service pathways and also the current delivery models for adults who have multiple complex needs as a real priority, particularly in the light of pressures on all the services and responding to the increasing demand that we're seeing. So we are really in this recommission expecting providers to deliver proactive, flexible, intensive outreach support to this particular group of women. And our strategic framework recognises that women experiencing multiple disadvantage might not present automatically as domestic abuse services, and it really explicitly recognises the importance of working in close collaboration with partners across housing and homelessness services, mental health, substance misuse and women's services. So we intend to work together by always putting those affected by domestic and sexual violence and abuse right at the centre of our work, maintaining a real focus on equality and inclusion and recognising that anyone can be affected by domestic abuse and sexual violence, but ensuring that marginalised individuals within our communities are represented, have a voice and are heard. Always being aware of the context in which domestic violence and sexual abuse takes place. So if it's taking place in the streets, to be mindful of that. Prioritising effective dialogue and communication between services, and by being brave, I think, in our innovations where the evidence is telling us to do things differently. And our last slide is just our contact details. Should you wish to pick any of this up with us, they're up on the screen now. And I think that's us finished, and we can hand over for questions or discussion.
Thanks ever so much, Vicky and Rose. That was really, really insightful and huge amount of work, I know, to A, bring all that together and B,